Good morning. I'm Reem Ali, Vice President at the Health Policy Institute of Ohio. Thank you for joining us for the Home Visiting in Ohio Capacity and Readiness Assessment webinar. I hope you are all healthy and well and doing as best as possible, adjusting to this new reality we are in. Before we get started, I have just a few housekeeping items for all of you. For now, everyone is in listen-only mode. We want this to be an interactive meeting, so if you have a question, please type that question into the question box. There will also be opportunities for discussion later in the webinar. During the discussion, raise your hand and we will unmute you. Keep in mind, if you've muted yourself, you'll need to unmute your audio. Again, to participate, please make sure that you have entered your audio PIN. You need to log into the webinar first before calling in order to get your PIN. You can find the agenda, slides, and a recording of today's webinar posted on HPIO's MCH McV Groups page. You can find this by going to hpio.net and clicking on Groups. HPIO was contracted by the Ohio Department of Health to facilitate development of the state's maternal, infant, and early childhood home visiting assessment, or McV, as you'll hear it be called throughout this webinar. As part of this process, we are gathering data and information on Ohio's home visiting landscape, with a specific focus on the capacity and readiness of home visiting providers in the state. Here is the agenda for our meeting today. You can also download the agenda under the handouts for this webinar. And here are the objectives for today's meeting. We'll provide an overview of the requirements of the McV Needs Assessment and talk about the purpose of the online survey many of you responded to a few weeks ago. We'll also be reviewing and getting additional feedback from all of you on the preliminary key findings from that online survey. Thank you very much to those who were able to fill out the survey. The information you provided is critical to get a pulse on the issues you all are facing across the state. And with that, I'll hand it over to Alicia Leatherman, who oversees the early childhood home visiting and maternal and infant wellness programs at the Ohio Department of Health, to provide more background and context on this work.
Good morning, everyone, and thank you to our colleagues at HPIO. They have been amazing partners for the Department of Health on a number of the needs assessment and planning processes that we are undergoing right now at the Ohio Department of Health. So thank you. You can go to the next slide. So I wanted to be able to just provide a little bit of context about this needs assessment, because as Reem said, we do tend to call it the McV Needs Assessment, which may lead people to think that it is specific only to the funding that we receive from HRSA for home visiting. But it in fact is a needs assessment that is intended to be much more broad and really give us a tool as a state to really think about what's needed for the home visiting system as we think about expansion and improvement. So the needs assessment is referred to as McV because it is funded with the dollars that we receive at the Ohio Department of Health and is a requirement of us to continue to get those funds to support home visiting services in our state. Just in terms of context, we have a system that we fund through the Ohio Department of Health. It's about $40 million this year. We receive about $7.5 million to fund McV and to fund communities that have been identified as high need. So these dollars, in order for us to maintain those dollars, we're required every 5 years to complete a needs assessment. And as Reem said, and you'll hear a lot more about it, really is for us to get a sense of the issues, the strengths, the opportunities that we see with the existing system and as we think about a future system. And as I mentioned, ODH is the lead for this process because it is included in McV, but we are engaging all of our other state agencies, sister agencies in this process. And it's intended to be a tool at the end that can be used by the Ohio Department of Health, our sister agencies, and any other local funders or communities that are thinking about expanding or implementing home visiting. Next slide. You'll hear a lot more information this morning about the response rate, but I just wanted to say thank you. Based on the number of surveys that we sent out, I think this is probably one of the best, highest response rates that I've ever seen in the work that I've done. So thank you for taking time to do that in place of our regional conversations. I also wanted to share that included in this conversation is a very broad group of home visitors that are operating here in Ohio. It does include providers that are funded by the Ohio Department of Health, by our colleagues at the Department of Medicaid and the Ohio Children's Trust Fund, and it includes community pathway hubs, early Head Start providers, Spark providers, Healthy Start, federal funders, and then as you can see, any additional locally funded projects that are supported at the local level. We also invited those local agencies to participate as well. I'm now going to turn it back over to my colleagues at HPIO to start sharing some of the information about the survey results, but look forward to this being a conversation and hopefully addressing any questions that may arise through the presentation.
Thank you, Alicia. Now I'm going to provide a brief overview of the purpose and requirements for the Maternal Infant and Early Childhood or McV Needs Assessment Update. Under federal law, Ohio is required to conduct a McV Needs Assessment Update by October of 2020. This is the first federal mandate requiring a needs assessment for the McV program since 2010. The purpose of the McV Needs Assessment is to gather updated information on community needs related to early childhood home visitation and to help ensure that McV programs are implemented and funding is allocated to areas of high need. There are 4 primary components of the needs assessment that you can see here on your screen. Using data provided by the Federal Health Resources and Services Administration to identify communities with concentrated risk or the greatest need for home visiting services, as Alicia mentioned. Assessing the quality and capacity of early childhood home visiting services, including gaps in early childhood home visitation, including the extent to which programs are meeting the needs of eligible families. Assessing the state's capacity to provide substance use disorder treatment and counseling services to pregnant women and parents with young children, and also identifying opportunities for state agency collaboration and coordination to meet federal requirements. HPIO has been working closely under contract with the Ohio Department of Health over the past year to gather data and information to inform all 4 of these needs assessment components. Through the first half of this year, we have been focused on gathering additional information and updated data to assess the quality and capacity of early childhood home visiting services. As you'll hear from my colleague Becky Carroll in a minute, a primary purpose of the online survey you responded to a few weeks ago was to help gather this additional information with a specific focus on the areas you see here. This is the federal submission timeline for the McV Needs Assessment. Again, the final needs assessment must be submitted to the federal government by October 1st of this year. And with that, I'll turn it over to Becky Carroll from HPIO to talk more about the purpose and process for the online survey.
Good morning, everyone. As Reem mentioned, my name is Becky Carroll. I am a policy analyst at HPIO. I'm going to be giving you some quick background on the survey, and then we'll dive into the findings. Again, as Reem mentioned, the McV Needs Assessment Update requires states to analyze the capacity of existing early childhood home visiting programs. As part of this, states are encouraged to assess community readiness through considering gaps in staffing, community resources and support, and other requirements for implementing evidence-based home visiting services and demonstrating improvements for eligible families. Due to COVID-19, the Ohio Department of Health chose to administer an online survey in place of regional meetings to collect this information from home visiting providers. The Ohio Home Visiting Provider Capacity and Readiness Assessment Survey was open for about a week and a half. It consisted of 23 questions. I want to mention that you may not have been asked to respond to all 23 questions. Based on your responses to some of the questions, the survey may have had you skip a follow-up question asking for more details. So some questions we go over today may not look familiar. There were a total of 99 survey responses, which is wonderful. Since we limited it to one response per organization, we know that in many cases, these responses were an organization-wide effort, not just an individual effort. So we really want to thank everyone who contributed to these survey responses. We had a total of 81 counties represented by at least one survey respondent. We had very good representation across all county types and across home visiting regions. Here you will see the 6 new home visiting regions that were introduced by the Ohio Department of Health earlier this year, which will become officially effective in July. We were also pleased to see a large variety of home visiting models and programs represented. The ones denoted with an asterisk are evidence-based home visiting models based on the Department of Health and Human Services Home Visiting Evidence of Effectiveness, or Home V list, which is used by the McV program. And in case some of you are unfamiliar with the acronyms here, SPARK stands for Supporting Partnerships to Assure Ready Kids, and HIPPY stands for Home Instruction for Parents of Preschool Youngsters. Both aim to improve school readiness. Now we're going to go through some preliminary key findings from the online survey related to capacity and staffing. The first question asked about the largest barriers impacting your ability to serve all pregnant women and families eligible for and requesting home visiting services. Here are the top 10 responses out of a total of 18 choices that included some others added in by survey respondents. The most commonly selected were challenges related to retention and initial engagement of families. Next was a lack of adequate funding. The fourth most common was about the eligibility restrictions of specific home visiting models or programs. And the fifth most common response was related to hiring challenges. And we'll dig deeper into that one in a few minutes. We looked at how the top 3 barriers selected varied across county types. You'll notice that there are 4 barriers shown for Appalachian counties because there was a tie for the number 3 spot. There was no barrier that was identified in the top 3 across all county types, but there were several that showed up in 3 of the 4. Initial engagement, as well as referral challenges, showed up in the top 3 for all county types except for urban. Interestingly, 2 of the top challenges identified by urban counties did not show up in the top 3 for any other county types. These were funding and administrative barriers. The only other challenge that was unique to a county type was hiring challenges, which was in the top 3 for Appalachian counties only. Here are the top 3 barriers selected by different home visiting models and programs. Safe Care Augmented, HIPPY, and the Healthy Start sites are not shown because they had very low response numbers. Interestingly, you'll notice that there was no barrier that appeared in the top 3 for all of these models and programs. Retention appeared in 5 of the 7, all except Early Head Start and Pathways Community Hubs. Inadequate funding appeared in 4 of the 7. Lots of the same challenges, however, popped up among the home V models, which is the table on the left. Retention appeared in all home V models except for Early Head Start. Inadequate funding was in the top 4 for Healthy Families America and Nurse Family Partnership, while initial engagement and challenges related to referrals appeared in the top 3 for both Parents as Teachers and Early Head Start. The only top 3 challenge unique to a home V model was hiring challenges, which was selected by Nurse Family Partnership programs. There was not quite as much consistency among the top 3 challenges identified by the programs in the box on the right. And there were more that were unique to a single program. For example, Moms and Babies First programs identified Ohio Department of Health eligibility restrictions and staff turnover and retention as top 3 challenges. Hubs called out data reporting and hiring challenges, and Spark programs identified initial engagement as their top challenge. Next, we asked all home visiting respondents how often their home visiting program has a wait list. Half of programs reported never or rarely having a wait list. 21% said sometimes, and a total of 28.6% said either very often or always. We broke the data down and looked at the percentage of programs in each home visiting region that reported very often or always having a wait list. You can see that the lowest percentage was in Region 3 at 17.7% of programs. The highest was in Region 5 at 42% of programs. We also looked across home visiting models and programs. The model with the highest percentage of programs reporting a waitlist very often or always was Nurse Family Partnership. And on the flip side, you'll see that none of our respondents representing Moms and Babies First programs or Pathways Community Hubs reported very often or always having a waitlist. Again, HIPPY, Safe Care Augmented, and Healthy Start are not shown due to small response numbers. The survey also asked if you are able to serve all pregnant women or families that are eligible for and wanting home visiting services through your program. Over 80% of programs reported that they are always or very often able, 15% said sometimes, and only 3% said rarely or never. Those programs who responded that they were sometimes, rarely, or never able to serve all pregnant women or families eligible for and requesting home visiting services were then asked, what are the most important things that would be needed or what would need to happen in order to increase your program's capacity? By far, the most common response was related to a need for additional funding or support to hire additional home visiting staff. The first survey question related to staffing asked programs if they have trouble finding and hiring qualified staff for home visiting positions. 27.3% of programs said they usually or always have trouble, and another 40% said they have trouble sometimes. All of these programs that sometimes, usually, or always have trouble hiring were then asked to identify the top 3 reasons why they believe they have trouble finding and hiring staff for home visiting positions. By far, the 2 most common reasons selected were compensation is too low to attract desirable candidates, and candidates lack required experience or degrees. The next most common responses were that candidates lacked the necessary knowledge and skills, and barriers associated with training, which includes such challenges as the availability and costs of trainings and the costs associated with hiring staff and not being able to get them trained right away. When we look at the top reasons for hiring trouble across regions, we see quite a bit of consistency. The top 3 reasons that showed up for the state overall were also in the top 3 for all regions except Region 5, for which barriers associated with training was the 3rd most commonly selected reason. A smaller percentage of programs reported challenges with staff turnover and retention. Only about 12.4% of programs reported very often or always experiencing trouble with staff turnover and retention. 35% said sometimes, and over 52% of programs said that they rarely or never experience such challenges. Those programs who reported that they sometimes, very often, or always experience challenges with staff turnover and retention were asked to explain why. By far the most common reason given was compensation. Stress and burnout were also commonly mentioned. Other responses in the top 5 were administrative burdens, career or professional advancement, and competing family or personal priorities. In this last category, programs often talked about the challenge of working inconvenient hours in these home visiting positions. I will pause here to see if you have any questions, and then we'd like to get feedback on the preliminary findings I just reviewed. As a reminder, if you would like to speak, please raise your virtual hand and we will unmute you. Keep in mind, if you've muted yourself, you'll need to unmute your audio. If you would like to speak, please also make sure that you have entered your audio PIN. You need to log into the webinar first before calling in order to get your PIN. Or you are also welcome to type your questions into the question box. So we'll give it a minute and wait to see if anyone has a question at this point. Okay, well, seeing no questions. Sorry about that. Seeing no questions, we'll move along to the discussion questions. Our first discussion question is, what did you find most notable about these findings? Again, please raise your virtual hand if you'd like to speak or type your comments into the question box. Okay, well, at this point, we'll go on to our second question. Our second question is, what, if anything, was not captured in these findings related to capacity and staffing that you feel is important to highlight? So if anyone has anything to say on either question, please raise your hand or type your questions or comments in the question box.
Becky, we do have a question around the counties that are in each of those county typologies, and if we could identify the counties that are in each of those 4 categories. And so we can certainly make that information available after the webinar so you can see which counties went into each of those 4 county typologies.
Wonderful. Okay, well, I think at this point, thank you so much for the question.
Oh, we have
We'll make,
one
oh,
more question.
okay.
And please do be thinking about just questions that you've had on what you've heard so far. And we'd really love your insight on what you found to be most notable or even surprising in the findings. That'll help inform our needs assessment. And if you do have anything else that you feel like wasn't shared or highlighted, we'd love to hear that as well. Don't be shy. Please raise your virtual hand. We love to hear other voices on the webinar. So I see a few questions coming in. I'll start with those. It would have been helpful to allow for more than one response from an organization. At CPH, we have several home visiting programs models. Thank you, Lindsay. We appreciate that. We know that this doesn't give necessarily the full picture. It does give us some information to go off of, but we'd love to hear from others about if there were other things that you felt may not have been reflected or captured in the findings, what those are.
Reem, do we have any other questions?
We have a few more coming in. Terry is asking, she'd like to know what credentials are required for home visitors. Does it have an effect on the ability to find quality staffing? So I think Becky,
that,
if you or Alicia want to handle that question.
yes, well, I mean, I will say, first of all, that the credentials required do vary somewhat by model and program. Alicia, I'll let you jump in and talk about the Ohio Department of Health credentialing requirements.
Yeah, so I do think that it's likely that there may be some variation based on the model requirement. So we first and foremost look at what qualifications are required by the national models that we fund. And then for Moms and Babies First, we have criteria and requirements for the staff that are working in that project. So we can, what's great about this data is that they are broken down by model so that we can see if there are differences in that recruitment and retention of staff and finding people with those qualifications based on alignment to the model fidelity for staff. In addition to that, we do have a credentialing process for Ohio Department of Health funded programs that require some specific trainings to be completed, both around being a home visitor and then also in meeting model requirements in order to be credentialed. So we could also take a look at if ODH funded programs had a more difficult time than our colleagues that don't have that requirement in addition to model fidelity.
Great, thank you, Alicia. Reem, do we have time for any other questions at this point?
I think we can go ahead and move on. If you had a question that you weren't able to ask yet, or you have additional thoughts, please go ahead and type those into the question box. We'll keep tabs on that as we share the rest of the preliminary key findings.
Okay, wonderful. Well, thank you very much again for your questions and your attention. I am now going to turn it back over to Reem, who will go over the rest of our survey findings.
Thank you, Becky. So the next piece of preliminary findings that we're going to share are related to community resources and supports, as well as recommendations for improving home visiting in the state. When asked whether there were adequate health and social services and family supports available and accessible to pregnant women and families with young children who were in need of those services, nearly half of respondents said yes, while the other half responded somewhat or no. We asked those who responded somewhat or no to identify where the most notable gaps in services and supports were. Here you see the top 10 responses. As you'll note, 50% or more of respondents identified that the most notable gaps were around childcare, housing assistance, and diaper banks. Also, notably, both parental and pediatric mental health treatment and services and supports were among the top 5 responses. We also took a look at top 3 responses to this question by the 6 home visiting regions. More than 3 responses are listed under a region in the event of ties, and red indicates a response that was unique to a home visiting region. Otherwise, common responses are highlighted in the same color. Again, housing assistance, childcare, and diaper banks were the most common responses across the regions, identified in 4 or more of the 6 regions. Pediatric primary care and specialty care services were identified as a unique top 3 gap in Region 1. Utilities assistance and car seats were identified as unique top 3 gaps in Region 3. And then additional baby supply assistance was a unique top 3 gap in Region 5. In the survey, we also asked questions to identify the extent of collaboration both among home visiting programs and between home visiting programs and early childhood education programs. Here you see responses describing the extent of collaboration among home visiting programs in a county. Notably, about a quarter of respondents indicated that home visiting programs in their county made or shared referrals and or provided transition support to one another, and also that there was strong collaboration and coordination in their county. Other top responses included having regular communication and meetings and sharing services, trainings, resources, and space. Nearly 15% of respondents, however, did indicate that there was a lack of collaboration or coordination in their county. Top responses by home visiting region were very similar. However, competitiveness was identified as a top 3 response in home visiting region 3, which is in the southwest part of the state, and region 4, which is in the northeast part of the state. And here you see responses describing the extent of collaboration among home visiting programs and other early childhood programs in a county. Again, making or sharing referrals and transition support was the top response. Nearly 30% of respondents indicated strong collaboration in their county, while about 20% indicated a lack of collaboration. Collaboration in the form of participation in a joint committee, council, or other initiative, and sharing services were among the top 5 responses. There were no notable differences in top responses by home visiting region and no responses that were unique to a specific home visiting region. Survey respondents were also asked to assess whether there is an understanding and appreciation of home visiting in their county. More than 86% of respondents said that there was either some or widespread understanding and appreciation of home visiting. Nearly 14% said that there was very little understanding and appreciation. Of those who said there was very little understanding and appreciation of home visiting, confusion and lack of understanding about what home visiting is were the primary reasons cited for why it appeared like there was not buy-in or support. Online survey participants were also asked how state agencies could work more effectively and efficiently together to support home visiting in the state. Top responses included promoting common goals between home visiting programs and partners, increasing automatic referrals to home visiting from Child Protective Services, WIC, and Medicaid, increasing public education and awareness of home visiting, increasing funding support, and promoting a unified home visiting approach, including common definitions. Increasing coordination of state-level meetings and communication across state agency and other local level partners also was identified as a top response. As many of you know, the governor convened an advisory committee on home visitation early last year and charged the committee with developing recommendations for achieving his goal of tripling the number of Ohio families served through evidence-based home visiting. The report includes 20 recommendations to expand and enhance the quality of home visiting services in Ohio. We asked survey respondents to identify which of the governor's recommendations were most important and should be prioritized for implementation. Here you see the top 10 recommendations, with expanding and streamlining eligibility requirements to increase the number of at-risk families that can be served as the top response. I'll give you just a few seconds to review this list. When asked why they prioritized the recommendations they had selected, the number one reason was to expand the number of families being served, followed by increased funding support for staff supervision, training, and retention, an increase in collaboration with and referrals from Child Protective Services. Promoting equity and culturally competent home visiting services and increasing public education and awareness of home visiting were also among the top 5 responses. We're coming to our final question, so please be thinking about any comments or questions you've had on any of the preliminary key findings that we've presented so far. So as a final question, we gave online survey participants the opportunity to comment on anything else they would like to discuss regarding their program's capacity to provide home visiting services to pregnant women and those families in need. Many of the comments or responses that we saw really reinforced responses that we had shared on other questions. The most common were concerns or suggestions related to family recruitment, referrals, or engagement, followed by comments about the need for additional funding support for home visiting and requests for increased recognition of specific home visiting models. Many respondents also emphasized that either they could or wanted to increase capacity. And finally, the fifth most common type of response was related to concerns about central intake and data access. For example, there were several survey respondents who mentioned that they do not receive any information about the families on their waitlists and how this information would be helpful in terms of making sure they were serving those with the greatest need. Now that wraps up the preliminary key findings from the online survey. We're going to pause for just a little bit to see if you have any questions. And then again, we'd like to get feedback on these preliminary findings that we've reviewed. If you do want to speak, we are happy to unmute you. Just raise your virtual hand. Now, keep in mind, if we do unmute you, if we do unmute you for raising your hand, you will actually need to unmute yourself. So if you've muted yourself, you will need to unmute yourself if you want to speak. And just make sure that you've entered your audio pin.
We
We
do have
do.
a question.
Oh, go ahead,
Um,
Alana.
oh, she took her hand down. Arisha, do you still want to speak? If so, please re-raise your hand and I'll be happy to unmute you.
In the meantime, I'm going to read a comment that I believe this one actually came in from Laura during the last portion of the presentation. Laura said, I wonder if the pay rate burden many responded with as a challenge was before or after the increase of reimbursement. I have not had to hire since then and think it will not be as big of a problem as it was before. Thank you, Laura, for that comment. We also did get a question about the slides and if they'll be available following the discussion. Yes, the slides are already posted on HPIO's website. If you go under groups and click on the MCH and McV group.
Great. We can move on to the discussion questions.
All right.
So they are very similar to what we had asked before, which is which of the findings did you find most notable? Was there anything that was not captured in these survey findings that you feel is important to still highlight? And then we'd also just like to ask you what else we should be considering in interpreting the survey findings and updating the McVie Needs Assessment. What information do you think is valuable for us to highlight or to share in the McVie Needs Assessment, or even explore a little further? Give you some time to think about these questions. Again, please don't be shy. We'd love to hear some more voices on the webinar, but also feel free to type your questions or comments into that question box.
Okay, I'm not seeing any comments in the question box at this point. Alana, do we have any hands raised?
We do not, but if you do raise your hand, please just leave it up until we get to you, or we think you changed your mind.
Okay, Sharon asked, can you tell us again how to get the slides? They are on the HPIO website, that is hpio.net, and you will see a groups button along the top. And if you go down and click on MCH and McVie, the slides should be posted there under additional home visiting information and resources.
Great. So I do see a few comments are coming in, or questions. One from Amy: is there a way in the future to talk about impact and reach? I think the value of the work could be shared. Oh, I see a lot more coming in as well. Amy, if you wouldn't mind, it would be great if you could expand on that comment. If you could raise your hand, Alana can unmute you. So I just want to make sure that we're fully understanding your comment.
I don't know if I have an audio pen. Can you hear
Well,
me?
we can hear
We can
you.
hear you.
Oh, good. Because I did it through my computer. No, I was just thinking about, with such a variety of programs and impact within particular counties, and it made me start thinking about, collaboration and what that looks like. And if we were to think about total reach and impact, it's one thing to have all of these programs within counties, but at the end of the day, what's the true reach? Are we getting to the people that we need to? Are we addressing equity? Are we eliminating health disparities? And are we able to demonstrate that? Are there particular programs that do more of a focus on that versus others? And how does that look across the state? I don't know if that's part of the needs assessment, but in my mind, when I think about what we try to look at locally in our county, it's how many people are we trying to get to? Did we get to them, and what's the impact? And maybe that's not what this is about, but I'm wondering if there's sort of a larger discussion that at some point could happen.
Absolutely, Amy. Thank you. Thank you for sharing that. The needs assessment is more focused on kind of the capacity and readiness of providers to serve families in need, but certainly an important part of the discussion is around the impact of home visiting services in the state, and which programs are reaching which populations. So I'm going to ask if maybe Alicia can speak a little bit more to that.
Sure. Thank you again for the question. It's exactly where I think we want to be thinking about how we define reach across programs, and being able to assess whether or not people are getting multiple programs is one of the things that is most on our mind, and helping with that coordination function and collaboration function at the local level. We also, the recommendations that were submitted to the governor also included a goal of having common measures or common ways that we define what impact means. And one of the things, Amy, that I think we're trying to do a little better, differently, is we've been in a place where independently, I think programs and agencies and models have been trying to do everything so we currently at the Ohio Department of Health have 4 goals around home visiting, and we, I think, are now starting to have more conversation about the models that best meet which deliverable, which outcomes, which impact, and how do we make sure in a community that there's a variety of programs that families can choose from based on what that family wants and needs to focus on most. So it's going to be, I think, an evolving conversation. I do think that some of the data that will be included in the needs assessment at the county level around reach will help us think about where we may need to focus and emphasize some of our work. And then I think having more specific conversations about really the wonderful research and data and information that the individual models can share and what they demonstrate, where do we have the greatest likelihood to impact those 4 measures that we may have for our home visiting system? There may be different models that are in a better position to address 1 or 2 instead of everyone trying to address all 4 of those outcomes in the same way. So I think it'll be an evolving conversation, but really appreciate your thoughts and your comments.
Thank you, Alicia, and thank you, Amy. Arisha is asking, can you share again what those next steps will be after the assessment is submitted to the federal government this fall? So we know that the Department of Health is planning to share the needs assessment once it is completed and submitted. As far as next steps, Alicia, if you want to jump
Sure.
in again.
Sure. So we will share. So the state agencies, the sister agencies, so one will make the materials, the tool, the results available broadly to the provider network, but also a larger group of stakeholders that we also try to keep in touch with. We also have 2 groups at the state, or 3 groups at the state, that we believe will be particularly interested in this information as we think about funding and collaboration and system improvement. The first is a cross-agency leadership team of the early childhood agencies that's convened by the governor's office, and specifically the director of children's initiatives for the governor's office. And that's where a lot of strategy and policy conversation happens amongst the state agencies. Another group is the Early Childhood Advisory Council, the Governor's Early Childhood Advisory Council, whose job it is to think about the early childhood system and its impact, a lot of the questions and the themes that were in the survey. What is the workforce? What do we need to be thinking about in terms of engaging families more effectively, about professional development in the workforce and the needs across the system? And that group is, again, convened under the leadership of the Children's Initiative, but has a much broader stakeholder representation. And I encourage you to, if you don't know who from the home visiting world and from your community may be participating, you can get information about the Early Childhood Advisory Council on the Bold Beginning website, and we can try to make that information available to you as well. And then finally, we do have a home visiting consortium that is required in statute. It is a fairly small group. It's about 15 people. It includes the state agencies, legislators, and a small number of providers. And that group's goal, that's different from the other groups that I've named that are looking at the broader, bigger early childhood system, is really focused on how do we think about expansion and system improvement around home visiting. So we'll also be using this information. We'll be presenting this information to the Home Visiting Consortium and aligning what information has come out of this needs assessment with the governor's recommendations to really identify the best next steps for Ohio to think about in terms of implementation.
Great, thank you. Thank you, Alicia. If you have additional thoughts or comments on that, please feel free to share or questions regarding what Alicia just discussed. Amy had a comment that she feels that there should be more of a focus on equity and systemic barriers and the role of home visiting programs in addressing these. Thank you, Amy, for that comment. Several folks have asked where the slides are. We've shared a link directly to the slides, so if you are able to just peruse those, and if they spark any additional questions, we do have a few minutes left to answer any questions that you might have, or hear any other thoughts that you might have about what else we should be thinking about in both interpreting these survey findings, but also information that might be helpful for us to include or highlight in the McV needs assessment, or even about future work that could take place as has already been shared. So I'll give you just another minute or so to think about that, and see if you have any other questions or comments. We are incredibly pleased by the number of responses that we did get through this survey. So 99 respondents, and did get a very good representation across county types, across the regions, the home visiting regions, and models. If there is information specific to your home visiting model that you feel really was not highlighted in the preliminary online survey findings, we really would appreciate you sharing that with us.
Reem, I also wanted to jump in and let folks know that under handouts, we've posted the list of Ohio counties and what county type they fall into. Someone had asked for that earlier.
Wonderful. Thank you, Becky. All right. Thank you for putting this information together and sharing it with all of us. It is our pleasure. We are hopeful that this is going to help inform all of your wonderful efforts in serving those families that are most in need of home visiting services, and making sure that we're able to really meet the needs of families that are most at risk, and this needs assessment can help to provide a foundation for that. All right, well, with that, I'm going to hand it over back to Becky to close out the webinar.
All right, well, everyone, we just want to thank you once again, for your participation in today's in today's webinar, and for your feedback. In terms of next steps, as was previously mentioned, the McV Needs Assessment update is due to the federal government in October, and the Ohio Department of Health does plan to post that final needs assessment on their website later this year. So again, thank you again for your participation. We hope that all of you are staying healthy, and that you have a very nice afternoon.